Welcome to Pause for the Truth, where you can sit back, relax, and hear an honest dialogue about health, wealth, legal, and social issues. The hosts are Dr. Rogers Kane, family practice physician, and Jocelyn Turner, health education consultant, with co hosts from the Northeast Florida Medical Society and its foundation. Stay tuned for the truth about matters affecting you and your family. We're here to tell you what's really going on and why. And welcome to Pause for the Truth. I am Jocelyn Turner, your co host. Oh, what a beautiful day in Northeast Florida. The weather is amazing. It's not too steamy. I didn't feel like I was going to pass out after my car had been sitting idle for several hours. How are you doing this evening, Dr. Kane?
I am doing well, and I didn't feel like I was a broiled wiener either uh, most of the day.
I can't with you, Dr. Kane. I just don't understand. I never, as they say, what comes up comes out. What
Yeah.
in the world? So, Dr. Kane, I'm excited to have this conversation with our guest tonight. But before I introduce him, oh, I would be remiss not to acknowledge our technology guru, Tyrone Jackson, who seems like he's coming from behind the camera this evening. Tyrone, you're muted, but do you have anything to say this evening?
I just want to echo your sentiments. Beautiful day to be in Northeast Florida.
Absolutely. So tonight we are pleased to have Dr. Otis Kirksey. I just met Dr. Kirksey, but I am anxious to hear from his expertise as we talk about managing diabetes medications. How you doing this evening, Dr. Kirksey?
Good afternoon. Well, actually, good evening. I'm doing great, and thank you for this opportunity to, share some insights on this topic, which is something that is near and dear to me. And you speaking of great weather, I live in Tallahassee. I'm on the highs of the Seven Hills here.
Hmm.
That's right, and we had beautiful weather today, so we all blessed in having a perfect day.
Sounds
Obviously,
like a rattler. Sounds
I
like a
was going to
rattler.
say, even though you may not be a rattler, if you're saying the highest of the Seven Hills, all rattlers know what that means. And
And for
obviously,
those of us who happen to have a brother and sister-in-law that graduated, we also know what that means.
Okay.
well, I think I got you beat. I think it's about four plus me that are FAMU rattlers. So that we're, to the day we die. I've told my audience before, I am a graduate of at least two HBCUs, and then I got that third, primarily not HBCU school that I also was a part of. But from day one, I remain a rattler to the day I die.
Are
Yes,
you
sir.
referring to the University of Florida? You can say it, Dr. Kane, but I'll say
I
it
will
for you.
refer to the University of Florida with some smackling of Emory in there.
Okay.
Dr. Kane, your picture is going in and out. I don't know what it is, but anyway, we'll let Tyrone work with you on that. But Dr. Kirksey,
Yes.
this subject of diabetes is unfortunately near and dear to my heart because I was diagnosed 4 years ago, as I've shared on the show. And after crying, I had to suck it up and dig into my intellectual knowledge of diabetes, having started so ironically my career as a part of a team of professionals at the health department at the time doing diabetes education. But I also tapped into my plethora of friends and said, what do I eat now?
Yeah.
Right. And
Yeah.
Dr. Kirksey, I know you're a pharmacist, and I'm also proud to say that in 4 years, I've not had to take any medication. I've learned to manage it otherwise. But I love pharmacists and all they all do, but I know you are a certified diabetes care education specialist and all those other initials or letters before your name. So
Yeah.
why do you think it's so difficult for people to manage their diabetes? Let me start out with that.
Well, first of all, that's a great question, and one of the things is behavioral. You mentioned it earlier. When you were diagnosed, you were in denial. You eventually had to get yourself together, right? And so
Right.
it's a scary road. And so a lot of people faced with that, it's challenging because diabetes is not, you just can't throw a pill at it. You can't throw insulin at it. You know, you have to, particularly the type of diabetes that affects African Americans and people of color, type 2 diabetes. You have to change behavior. And oftentimes that behavior change is influenced by social determinants that we have no control over. You know, I every day I manage patients at a very qualified community health center in Tallahassee, and we are a what we call a safety net center. So these patients either they have no insurance or they have insurance and they uninsured. You know, you got insurance, but you still can't benefit from it, right? So and I was at a meeting last week at the American Diabetes, the Board of Directors for American Diabetes Association, and I was telling, I said, look, we have great standards of care that guide primary care providers and endocrinologists on how to manage the disease. But when you tell a patient that, look, you need to eat a certain way, that's expensive. It's much, much more expensive to eat healthy than it is to eat, you know, the way most people have access to. A lot of our patients, a lot of people in our community live in food deserts. So having access is one thing, not to be able to afford the food, but the other thing is to be able to access the food. And so when we say food desert, that means that you got food, you got fresh fruits and vegetables, good cuts of meat within, you know, walking distance, you know, and so those are the things that are barriers that make it so challenging to manage this disease. And you mentioned about the medications there. I'm sure we'll get deep into it, but you know, even if you had perfect glucose levels, right, you would still experience some of the chronic complications from the disease because you still, even though your blood glucose, your A1C is controlled, diabetes is, the people die from heart attack and stroke. So we've already found out that even by containing the A1C, getting the A1C down, there is still room, you know, need to reduce your risk of cardiovascular disease. And so we think about the drugs that we have available now. When Rogers and I was in pharmacy school, you know, he's much older than me,
Yeah.
But you know, we had drugs like, you know, these old sulfonylureas, insulin made from animal sources like beef and pork. They were associated with a lot of side effects, allergic reactions. Now we have insulin analogs. They work fast. Their action is dependable. Okay, less associated with hypoglycemia. And the newer drugs that we have, you know, for the first time, we have an arsenal of medications that not only can get our patients to the A1C goal, but they also address the other comorbidities that so often affect the increased risk of cardiovascular disease and weight. Okay, in terms of losing weight, and you know when you put a person on insulin and you tell them to lose weight, well, that's like giving them a backpack full of 40-pound weights and tell them to climb up the mountain, because insulin makes you gain weight. Period. So these new drugs not only help control blood glucose and all those good things, but they also lower risk for cardiovascular, what we call MACE, major atherosclerotic cardiovascular disease. Okay, some of them actually reduce risk or progression of kidney disease. So these are the things. Now, the challenge our community has, and I know I'm way past your question, is we got all these great drugs. But I noticed on one of the things on your website, you talk about health equity. I didn't say health equality, health equity, right? Mm-hmm. You can give everybody a ticket to go to the baseball game, but if I'm sitting behind, somebody 6'5", I can't see the game. Mm-hmm. All right. We talk about health equity, meaning that, everybody has an equal opportunity to have access to those medications, right? Irregardless of what their color, their race, their social economic status. And so this is going to be the fight of the future in terms of they have already laid out. We know how good these drugs are, but because they cost. Okay, and we'll talk about that in a little bit in terms of the price. You know, the insurance companies have all these different, you know, barriers to access them, prior authorizations, and all of this. And so, you know, again, the outlook is great, you know, but we still have a lot of work to do as it relates to, you know, managing the disease.
You brought up a lot of different things. I want to first point out one thing that you said. And I told people initially, I remember telling someone initially years ago, this is before my diabetes diagnosis, but I told them that culturally, when I walk in the grocery store, I'm accustomed to purchasing certain foods, right? And if I am diagnosed with a chronic health conditions, now you telling me to look at other foods that I have absolutely no idea how to prepare them, what they're about. So I like that we have access to several African-American registered dietitians who can who are familiar with our foods and just can simply share with us the best way to prepare those foods, right? Another point that you made so many great points, but I am working locally with the Black Church Network. And it is one way that we are addressing food deserts by encouraging Black churches to have community gardens or gardens on their church properties and make those fresh vegetables accessible to the surrounding community. So, Dr. Kane, you look like you had a comment or question.
Well, I was going to acknowledge Dr. Kirksey. What's unique to Dr. Kirksey, and one of the reasons I really wanted to have him on the program, was that not only does he recognize because you know in the past we've had excellent dietitians, you know, in particular we're speaking of Linda Brown on our program in terms of how to eat healthy, you know, but we never really integrated how what we call pharmacotherapy, which means how to treat them with medications after we try to influence our patients with dietary changes. And like I say, we try to influence them. And what we see a lot of, and you mentioned it, Ms. Turner, when you said when you walk into the grocery store.
Yeah.
You walk in that grocery store, you have to go way to the back to get to the healthy foods. They want to put all that good stuff, the sweet stuff, the junk food, the things that are very pro-diabetes oriented. They put that all in front of you to tempt you as you coming in and as you going out. And so, and particularly in our neighborhoods, you know, those aisles are full of junk food, you know, and I say our neighborhood, I'd be realistic, is more in the neighborhoods where I work at, which is in the Black community. You see more of that for what few grocery stores we have. But in the white community, we don't have all those aisles clutter filled with junk food, you know, that tempt you cheap junk food at that.
Yeah.
And the last thing, just to bring home a point that Dr. Kirksey made, is that even when we get our sugars under control, or think that we've gotten them relatively under control, we still have the ill effects that diabetes bring to the body, and the basic source of that ill effects is bringing to the body relates to the toxic effect of excess sugar. Okay, and the effect that it has on the lining of your blood vessels, in which we can get way into. I mean, we can get into the weeds about how it does that.
Yeah. Dr. Kane, get into it, because I don't think many of us understand that.
Yeah.
Dr. Kirksey, you want to grab it?
Well, you know, one of the things is that, you know, you have change in lipid metabolism. All right, which is
metabolism for those that don't know.
Exactly. So, you know, all of that, you know, there is a direct relationship to the, you know, excess hyperglycemia, the insulin resistance, and increased risk of clotting and coagulopathies and so forth. And so, you know, it's the hyperglycememia is the key. He mentioned it, right? You have vascular changes, you know, in the endothelium of the blood vessels, in addition to the consistency of the blood. It's thicker. And so, we tell patients, one of the things they recommend, you have diabetes, you take an aspirin once a day. I mean, unless it's contraindicated, because people have strokes. But I wanted to go back and mention something that you mentioned earlier in terms of the foods. You said, Dr. Kane, when you go into the stores, I mentioned about food deserts. Well, the opposite of a food desert is a junkyard swamp. Okay? Junk food swamp.
Right.
That's exactly what we have in our neighborhoods. Our neighborhoods is inundated with corner stores, right? Corner stores that there's no fresh food there. You got foods high in carbohydrate and caloric dense, foods. And so that's what people are shopping at, where you can't get to Winn-Dixie or whatever. Then you go to the store, you go to Dollar General. Okay, and they're trying to do a little something at Dollar General and the dollar store, because so many people have been on them about offering healthy alternatives, because no one has access to. There's no other sources there.
Right.
Yeah.
Cookie, cake, candy, sweets, all that stuff is readily available.
When you guys,
the other thing is, sugars have such a toxic effect on the lining of the blood vessels that they increase the capability of cholesterol molecules to penetrate that first layer, which we call an endothelium, that first layer of that blood vessel. And when that fat gets up under that first layer, you have cells called monocytes, that white blood cells. You have the white blood cells follow that cholesterol into up under that endothelium, and they become little Pac-Man.
Yes, that was like an immune response.
And they start gulping up those fats that have penetrated that first lining of that blood vessel. And that blood vessel is that initial lining is one cell layer thick. But it is a very powerful cell layer as long as it is allowed to do its job.
Yeah.
And when you get into that inflammatory response and you get those white blood cells going in, trapping, gulping up those that fat that has penetrated up under that into that blood vessel, you now have what we call macrophages, and they become foam cells, which means they're full of fat, and you can no longer, the body take that as being a foreign material. And because it's a foreign material,
inflammation,
if it winds up in any form of fashion getting back into your blood vessel, that body will attack it because it's considered foreign. And sometimes you will get an instant clot if for any reason you have a rupture of the lining of that blood vessel. And that is where hypertension and some of the other ill effects that we, as a community, Black folks, high blood pressure, diabetes, and elevated cholesterol, that's where we start the work, where the rubber meets the road.
Dr. Kane,
Dr. Kane, would you just pause 1 second? Dr. Kirksey, hold on 1 second. I want to pause for 1 second. If you're just joining us, we're having a very great conversation with Dr. Kirksey, and Dr. Kane is chiming in as our resident primary care physician. We're having a conversation about managing diabetes. So if you have questions, chime in now. There are a lot of us who are living with diabetes on a regular basis. Dial in now, 888-669-280. Tyrone, I hope I have that right. I hope I have it memorized correctly. Again, 888-669-1280, because now is the time for you to ask your question. We have Dr. Kirksey, even though he's in that other town with that other school. He's still a smart, great resource for us.
The good school.
The good school, right? Neighbors of the other school. But anywho, I don't know who wanted to say something first.
Dr. Kirksey.
I just wanted to say, Dr. Kane, you explained it perfect. What you have just described was an inflammatory response. Inflammatory response, and one of the things remember COVID, right? Know, and one of the things you said about people with diabetes being at increased risk because COVID was associated with an exacerbation of inflammatory response. So This is exactly what we're talking about. You're right on point, sir. You're smart as they say you are.
Who said that?
You mean other than my
Who's
co-host
spreading
here?
that rumor?
Who's spreading that rumor? My goodness.
But you know,
Percy, you must be on the payroll.
one of the things I wanted to share with you is the you know, in dealing with patients every day, and you know, you have those patients who are your superstars, and you get them and they come in and they're frightened, they don't know what to do. You empower them with the education and the information they need. Their A1C is like 15. They do the things that need to be done, taking their medication every day. They're exercising, the best to their ability. They're, trying to eat right. A1C goes down. They're monitoring. They're doing those things that need to take place. And the A1C goes from 15 to 6. I mean, that's the perfect world. And it happens a lot. But so many of the patients I deal with are stuck in the denial mode. And so, one of the things I tell patients is that the worst thing, the most dangerous thing about diabetes is that it don't hurt.
Right.
It don't hurt.
Sneaky.
I mean, it does not hurt. And so you can have a patient who, they're sitting up in the office and their blood sugar is like 450. And they think everything is good. Did you check your blood sugar this morning? No. Did you take your medication? Well, I take my medication. I take it every other day. Right. And so they don't understand that while it might be quiet, and we mentioned earlier in terms of, what happens. It's not pretty. Who wants to be on dialysis? Who wants to be blind? Who wants to, have, a one side paralysis? All these things happen. They happen for real. And so that's one of the things that I try to get across, the patients in terms of trying to get them to appreciate the seriousness of now and the fact that we have to act now, and that, when you go to the store, there are ways that, we have to teach people to eat what they like to eat, but how to eat it right. You mentioned that earlier, Ms. Turner, in terms of you go to the store, you see the foods you like, right? But you don't have to go on this crazy diet to manage diabetes. You need to know the foods that raise your blood sugar, the foods that don't, and the foods that put weight on, and the foods that don't. Foods that lower your postprandial blood sugar, like foods rich in fiber, like collard greens and carrots and all the pretty stuff. You balance that kind of food, with those little bit of carbs you eat, like your potatoes or your rice, whatever. You can actually nullify that glucose rise after you eat if you get in enough fiber. So, right. Having the correct, instruction and education and direction, people can be taught how to enjoy their meals, not feel awkward when they go out to eat and so forth.
Well, let me just say this, Ms. Turner, before we jump to one other part of the program, is those collard greens are good until you throw in because they're vegetables, okay?
I know you
throw in the fat back. Now they become a meat.
That is a problem.
Let me say this. One of the main reasons I wanted Dr. Kersey here was for us to get to the medications and making sure that we all get a taste of medication, because like we said in the past, we've had Dr. Linda Brown come in and she's given us some excellent points on managing our diets and as it relates to diabetes. But I regularly wanted to make sure we get to medications. Okay. But before we do that, we going each week now, every time we have a broadcast, we want to get to our Black History moment. Okay. And, seeing as how most of us look black that's on this broadcast, we're gonna go ahead. Tyrone, let's take it away and give our Black History moment.
Welcome To pause for the Truth's History Makers Minute, September 19, 2023. As we reflect on the past and present, it is important to recognize the people who have made significant contributions to America and the rest of the world. Today we present Jocelyn Elders. Born August 13, 1933, Jocelyn Elders, the first person in the state of Arkansas to become board certified in pediatric endocrinology, was the 15th Surgeon General of the United States, the first African American and only the second woman to head the U.S. Public Health Service. Long an outspoken advocate of public health, Elders was appointed Surgeon General by President Clinton in 1993. Born to poor farming parents in 1933, Jocelyn Elders grew up in a rural, segregated, poverty-stricken pocket of Arkansas. She was the eldest of 8 children, and she and her siblings had to combine work in the cotton fields from age 5 with their education at a segregated school 13 miles from home. They often missed school during harvest time, September to December. After graduating from high school, she earned a scholarship to the all-black liberal arts Philander Smith College in Little Rock. While she scrubbed floors to pay for her tuition, her brothers and sisters picked extra cotton and did chores for neighbors to earn her $3.43 bus fare. After college, Elders joined the Army and trained in physical therapy at the Brooke Army Medical Center at Fort Sam Houston, Texas. After discharge in 1956, she enrolled at the University of Arkansas Medical School on the GI Bill. Although the Supreme Court had declared separate but equal education unconstitutional 2 years earlier, Elders were still required to use a separate dining room, where the cleaning staff ate. Elders did an internship in pediatrics at the University of Minnesota, and in 1961 returned to the University of Arkansas for her residency. Elders became chief resident in charge of the all-white, all-male residents and interns. She earned her master's degree in biochemistry in 1967, became an assistant professor of pediatrics at the university's medical school in 1971, and full professor in 1976. Over the next 20 years, Elders combined her clinical practice with research in pediatric endocrinology, publishing well over 100 papers, most dealing with problems of growth and juvenile diabetes. This work led her to study of sexual behavior and her advocacy on behalf of adolescents. She saw that young women with diabetes face health risks if they become pregnant too young, include spontaneous abortion and possible congenital abnormalities in the infant. She helped her patients to control their fertility and advised them on the safest time to start a family. In 1993, President Clinton appointed Dr. Elders U.S. Surgeon General. Despite opposition from conservative critics, she was confirmed and sworn in on September 10, 1993. During her 15 months in office, she faced skepticism regarding her progressive policies, yet continued to bring controversial issues up for debate. As she later concluded, change can only come about when the Surgeon General can get people to listen and talk about difficult subjects. Hello and welcome to Pause for the Truth.
That was wonderful.
All righty.
It was
Ms.
during
Jocelyn,
that
I wanted to say before you get started that, I looked at this woman and I tried to condense all her accomplishments down. We try to keep it into a short, but the list just continued to go on and on. So this one was a little bit longer than normal, but I figured since her name was the same as our co-host, I wouldn't get any pushback.
Similar, Jocelyn. She was Jocelyn Elders.
Whatever.
I forgot about her, and I'm happy, Tyrone, that you selected her for tonight. And it is a moment that we should remember. Tyrone, I think earlier you had a question. Did you get a chance to ask it?
Well, no, I think Dr. Kane jumped right in on what I was saying. The only thing that continues to come to mind, and I don't want to take us off because we want to get into medication today, but I always want to know, what are the alternatives? I heard Dr. Kingsley say that, we got food deserts, we got all these challenges, but what are the options for combating or the opposition for what folks are up against?
Yeah.
That is a topic, be quite frank with you, because that's the social determinant of health that relates to significantly. That by the time we get through with that discussion, we wouldn't have any more room for
Right.
any more room for the discussion on medications.
Yeah, when Dr. Kane and I talked yesterday, we were saying that, it's all connected. And so when you look at the politics piece, because a lot of things, if you look at Florida and compare Florida to some other states, you know, most people can qualify for Medicaid in Florida. Florida never expanded Medicaid so more people would have access. They refuse to do it.
Affordable
You know,
Care
so
Act.
it's like shooting in the foot. So, you know, they'd rather for people to have a catastrophic, you know, occurrence or incident before they you can get on Medicaid, a stroke or whatever, before they can you even qualify. So, you know, your point is very, very, very important, but it's very complicated, and there are a lot of different components of that the answer to your question.
So I want to talk about, let's talk about medications.
Okay.
So what medications, and I'm going to tease with you, Dr. Kirksey, because I'm thinking of the lady dancing in the park with talking about Ozempic, why we need to get on Ozempic. Yeah. And so what medication, and it seems to be the medication of choice in circles where I travel, because people like the fact that you can lose weight off of it. So tell us about and I don't want you to tell me the best medications, but what seems to be the most effective medications?
Well, what I'll tell you is based on the ADA recommendations, the American Diabetes Association. And so, you know, because we've gotten so much research that has come in, positive research demonstrating the benefits of certain drugs, you know, now there's an individualistic approach. Okay, you know, it is a patient-centered decision-making process in terms of what drugs you're going to go on. If you're someone who, if you're type 2 diabetes, and you have major risk for cardiovascular events, if you have a past history of a major cardiovascular event, if you have a history of chronic kidney disease and so forth, you know, the ADA recommends that you start at least either what we call an SGLT2 blocker, which is like Jardiance or Farxiga, okay, or a GLP-1 analog, such as a drug such as Trulicity or Ozempic. And you know, the weight loss piece is just icing on the cake. Okay, these drugs are effective in lowering your blood glucose without the risk of hypoglycemia. Hypoglycemia, you know, that is probably one of the most frequent causes of visits to the hospital for patients on insulin therapy or those drugs that cause insulin to be released. So, you know, frequent hypoglycemia is just as bad as having hypoglycemia. Matter of fact, hypoglycemia kill you faster than hyperglycemia, because if your blood sugar drop too low, you won't be able to do anything, right? So that's one of the great things. So matter of fact, so what they actually recommend starting these drugs before you start insulin in many cases. You know, now certainly if someone's having significant hypoglycemia and so forth, you may use a combination. If you look at the insulins, there are two major categories of insulins. We have what we call rapid acting insulins and we call basal insulin. These insulins are very slow acting. They work throughout the day. A basal insulin example would be Lantus or Levemir or Tresiba. A rapid acting would be like Humalog or Novolog, okay? In the old days, you know, you would see a lot of patients taking the Novolog or the Humalog, you know, right before the meals, right? And they'll take the long acting maybe at night, or is normally given once a day. But when they come back and you find out they're bottoming out in the middle of the night, or they're bottoming out, you know, if they skip lunch, they're bottoming out. And so you can actually get away with removing Novolog or a rapid acting insulin in many cases and adding a GLP-1 because the way GLP-1s work, they only work when food is in the gut. So is glucose dependent. They cause glucose dependent insulin release. So you'll get that insulin spike with that meal. You know, so we've got, you know, really moved a lot of our patients, away from the Novolog and Humalog. Certainly, there's some patients that cannot tolerate those newer drugs. They do have side effects, and so every drug has a side effect. But I think the important thing is that you educate patients to let them know exactly. Look, drugs like Ozempic or semaglutide or Trulicity. I hate to give these brand names because nobody's paying me, but this is what patients can identify with. Look, they're going to cause nausea. They may cause some vomiting. If you overeat, they're definitely going to cause nausea because they slow the absorption and GI motility, right? So they slow everything up. You can cause actually issues with the gastric, getting backed up in terms of peristalsis, in terms of the gut not moving at all. Paralysis of the gut, I guess you would say. So they could be, and then the most serious one is that you can have develop pancreatitis. So even though that is not something we see often, those are side effects.
Dr. Kirksey, the one thing that we have in this show, we have professionals, people that really understand the lingo that physicians and pharmacists talk sometimes, but we also have a lot of lay people listening. So, I like to give definitions at time, and Dr. Linda Lockett Brown brought it up. I really like to have definitions with things at times for what it means, to kind of break it down to layman's terms to what our audience is listening to.
Yeah.
For instance, you were referring to peristalsis of the GI tract, which is gastroparesis, which means your gut is not moving at the level or the speed that it was moving previous to starting this medication. But I want to get to two basic things. And can you explain to us the difference between type 1 diabetes and type 2 diabetes? Because I have patients coming in all the time.
Certainly.
Am I type 1 or am I type 2?
Okay. So type 1 diabetes often occurs in early years, okay? 3 and 4, 5 and 6, definitely before the age of 30. Type 1 diabetes is associated with an absolute lack of insulin. Your body oftentimes there's an immune response that comes in, and it actually attacks the beta cells and actually prevent them from producing insulin. Insulin is essential hormone in terms of managing glucose. It's like, I call insulin like the butler. It opens the door so your glucose can get into the cells. For you laypersons out there, think about a car with a full tank of gas, right? And the engine won't turn over because the carburetor is blocked out. The engine can't run until the gas gets into the engine. Well, the same thing with diabetes. Our cells need gas. They need energy, and glucose is that. But glucose cannot penetrate that cell unless insulin is there to open the door. So patients with type 1 diabetes do not make insulin, and they will go into what we call ketoacidosis if they're not treated, okay? Meaning that the body begins to break down fat to make energy. Your body is going to feed itself one way or the other, and so it will try to make energy from fat and muscle, and they end up going into what we call DKA, diabetic ketoacidosis, which is a life-threatening situation. Patients with type 1 diabetes are treated with insulin, period. Okay. Normally it's a long-acting insulin and a rapid-acting insulin, or they're on an insulin pump. Type 2 diabetes is totally different. Let me also say that we're also seeing now more of what we call latent autoimmune diabetes, in which it looks like it's type 2, but it's not. It happens later on in life. So there's some other things in addition to type 1 and type 2. Type 2 diabetes often affects people of color. It occurs later in life, even though now we're seeing a higher incident of type 2 diabetes among our young adolescent kids, African American, Black and brown kids, and a lot of it's associated with obesity. Obesity is probably the most profound predictor for the development of type 2 diabetes. Now, having said that, I also want to go back and talk to my skinny brothers and sisters out there, because just because you're skinny, man, don't mean you can't get type 2 diabetes, because it's not only that, but also who you are, your family. So if you have a mother, a father, an uncle, a brother, or sister who have type 2 diabetes, you're at high risk. If you have type 2 diabetes, your kids are at risk. And that's why we have to teach people to start training their kids to eat right and be active and so forth. So the major difference with type 1 and type 2 is that people with type 2, even though they make insulin, the insulin does not work. Okay, so we call it insulin resistance. And so that's the major difference between the two. And therefore the treatment is different. All the drugs I spoke about earlier, those drugs are not used in type 1 diabetes. Okay, there's difference in the pathophysiology. Type 1 is an autoimmune disorder. Okay, and I mentioned that earlier in terms of the immune response attacking. Type 2 is really like a metabolic disease. There's a lot of different things going on. You got inflammatory processes taking place. When you think about obesity, it's also about like where you fat at. Now they know that abdominal obesity is associated with higher rates of insulin resistance. Okay, so you're more likely you're built like a pear as opposed to built like an apple as opposed to built like a pear. So all those things come into play. And I would say that pretty much sums up the major difference in terms of between the type 1 and type 2.
So
One
when
of the
you
things
talk
I love.
about type 2 diabetes, I'm sorry, Dr. Kane.
Go
When you
ahead.
talk about type 2 diabetes and the benefits of medication. So I mentioned at the onset that I have, fortunately, even though I have an appointment in 2 days, but I have been escaping taking medications. But I know that there are benefits of taking medications to control your diabetes. Let's talk about those, for example, especially with those folks who have type 2 diabetes. But I also want you to mention a little bit that medications is not the only way to control the diabetes.
Yeah, I just saw someone say ketoacidosis can also occur in type 2 diabetic. Yeah, it can. It's just not as rare. It's just not as occurs often.
Frequent.
Right, it's frequent. I meant, yeah, it's just not as frequent. So you're right. Now go back to you see these questions are popping up or statements, and I'm getting distracted. So you're saying your question was to talk about
the benefits of the diabetes medication.
Well, first of all, when we think about the ideal medication, you're definitely looking at glycemic control, okay, and being able to lower the glucose. And remember now, when I talked about what drugs you pick, if your A1C is 7, right, then I may not, you may not be put on a drug like a GLP, like Trulicity or Ozempic, because you don't have that far to go. You only have like one percentage point, to get where you need to go in terms of the ADA recommends an A1C lower than 7. That's the goal for most people. Okay. There are some folks like, they have more aggressive goals for their patients, like less than 6.5. But, we don't need to shoot a mosquito with a shotgun. So depends on what your A1C is, would decide what drug you're on. Okay. So if you're experiencing a lot of hyperglycemia, your blood sugar is really, really high, then you need a big banger. You need to get those blood sugars in control. And so you're going to need a basal insulin, maybe, and one of these other newer drugs I spoke to or whatever. But that's how we'll make that decision based on, what your A1C is and what your other comorbidities are. Mm-hmm. Okay. So, I mean, if you someone who have a history of pancreatitis, you can't use, those drugs. No one should use them in that environment. Then the choice of medications may be different. If you don't have insurance, that's a major decision in terms of how do you access those. We would like to put everybody on those drugs, but everybody can't afford them. So in those situations, then we have to go with old school. There are insulins now you can get fortunately, most of the companies coming down $35 a month insulin, so that's good. Okay, so we can always go to old school if we need to. That's like a sulfonylurea, which is a drug that actually makes the body produce insulin. An example of that would be glimepiride. Okay, it's a good drug. Okay, I mean, you can get where you need to go if you use it in combination with other medications. So the older drugs, not that they're not effective, we use them when we have to. Okay, but it all depends on who the person is and what their situation is.
Yeah,
there was and I'm glad you mentioned it. Just real quick, Dr. Kane, just a comment. I'm glad you mentioned the cheaper prices, if you will, the more affordable. I'll say more affordable, because I was going to ask, are there any pharmacies that are pharmaceutical companies that offer assistance to patients who cannot afford their medications?
Yes, that's a very good question, because, as I mentioned earlier, the clinic where I work at, most of our patients are Medicaid. They could be insured, but the co-pays are so high, they still can't access the medication with their insurance. Okay. So oftentimes what we do is our case management department actually processes their patient assistance applications. So, I mean, all day, I'm sending applications to Novo Nordisk or to Lilly, for access to their medications. And so most of the medications are on the patient assistance list. They'll get a 90-day supply every 3 months, every 90 days for a year, and and at no cost. Okay. But the challenge is having someone to do the application and follow up with it. And oftentimes in a regular doctor's office, they may not have time to do those kind of things. But I would say for someone who is uninsured and is listening to us, you should engage with a very qualified community health center. They're in every county in the state. And so they have access to a special formulary, 340B pricing program. Like, I can send a patient to Walgreens and get a month supply of long-acting insulin, talk about the good stuff, for $15, period. Okay, so there are some options out there. There are some resources out there, but oftentimes people just are not informed. The other piece is that if you are on Medicare and you're in the donut hole, everybody know about the donut hole, right? So when you paying $30 copay, and then all of a sudden your copays jump up to like $150
or more,
right? Well, you can actually get patient assistance. I mean, I know the government has some things they're trying to do to fix the donut, but yeah, the drug companies will actually approve you for patient assistance if you are in the donut hole. So that's another resource you need to know about.
One of the best things the Biden administration has done is getting us cheaper prices on our insulin. But I would like to go back and touch base on something mentioned earlier. We can get those cheaper drugs like the glimepiride or the glucotrol, the old-fashioned, what were at the time the premier drugs to use.
Right.
Problem with those, I say that they're unforgiving, which is basically, once you take them, they're going to lower your blood sugar. If you don't eat, they're going to lower your blood sugar. If you do eat, they will lower your blood sugar. But when you don't eat, they will lower them a lot more than what you want them to. And as Dr. Kersey mentioned earlier, you will die.
Yeah.
If your blood sugar gets too low. Okay. And I think everybody knows that's the hypoglycemia he's mentioned.
Yeah.
You will die. And so I tell patients quickly, I'd much rather have you with elevated blood sugars, not perfectly controlled, than trying to overshoot and get these blood sugars that are too low. Now, one other thing I want to throw back out there, and that is the insulin resistance. Insulin resistance, by my definition that I tell my patients, it means it takes more insulin to do the same thing less insulin did before. Okay? A lot of people have insulin resistance 10 years before, 10 to 13 years before they actually develop diabetes.
Yeah.
And one of the things that some people are looking at times, they look at metformin and they try to start them early. I never fuss about that. The biggest problem with metformin is maybe the GI effects. Okay. The diarrhea it might cause, the gas, the bloating, stuff of that nature. And so and if we can't do metformin, we do have some people that go for the glimepiride. I usually do that only temporarily because, in my opinion, they tend to increase insulin resistance over time. So people wind up being on insulin. So when you start taking a look at the newer drugs, as he says, the SGLT2, which is serum glucose transporter 2, whatever that is. When you start looking at those drugs, they do a great job at helping to control your sugar, because what they will do is they will help you, for lack of better description and appealing to my audience, they will help you peel away some of that high sugar that you have in your bloodstream. Okay. By doing that, that's how they hope to control the sugar. Now, one of the other beneficial side effects for them is that they improve your renal function, your kidney functions. Some of them have been shown to improve your cardiac status. And then when you get to the GLP-1s,
and blood pressure.
Absolutely.
Yeah.
When you get to the GLP-1s, the glucose-like protein, that's something that is made in the body. So the Ozempic and the Trulicities and some of the other newer ones that are out there, those guys will basically do about 5-6 different things. They make your body more sensitive to your own.
They hit it.
Yep. They hit
multiple metabolic defects.
There you go. And the things that they do, and Dr. Brown mentioned right away, though, they fatigue the pancreas, so the insulin is needed sooner. That's why I talked about that. But anyway, the GLP-1s will wind up make your body more sensitive to your own insulin, make your body make more insulin. Okay. Also, they affect your glucagon production, which is the opposite of insulin. It does the opposite. That's why when people at late night, people go to bed and their sugar looks kind of good, maybe 100, 110, wake up the next morning at 165, 200. It's going like, I promise you, I didn't get up and go to the refrigerator and eat some ice cream. That's because glucagon doesn't know how to turn itself off. Okay, the body can't turn it off.
Another good feature about the GLP-1s is that they also preserve beta cell. So they actually, So they actually
and beta cell produces insulin.
Yeah, exactly. So when you can get a drug that does multiple things, right? Now there's a drug that's coming out in the next few months. It's a trifecta. It's not like Mounjaro has 2 incretin hormones. It has a glucose insulinotropic hormone, GIP, and it also has GLP-1, right? So the new one is going to have agonists for GIP, GLP-1, and a blocker for glucagon.
Good, excellent.
So that's a 3-way. That's going to be a trifecta.
Trifecta. The one thing I want to say is, and Ms. Turner, before we get to we getting close to the our show. One thing I want to say is to finish up on the GLP-1, because so many people are going after those GLP-1 agonists, which is the Ozempic and the Trulicity, the ones that help to lose weight. And one of the reasons, when I talked about what the effects that they have, one of the other things they do early on. Now, don't forget, GLP-1s are produced by the body as soon as you start eating. Your gut secretes it, and the GLP-1, which these drugs mimic it, they pretend like they are GLP-1s. They will send a message to the brain to tell you you're full. Okay, they send a message to the GI tract and slow it down. Okay, significantly to keep you feeling full. Problem is, with some people, and one of the big things we're seeing these days is what we call a gastroparesis. it slows it down so much till I'm getting a lot of people that, chronic constipation,
Yeah.
other issues. Dr. Kirksey, you can elaborate on that, but
Yeah. Well, we don't. To tell you the truth, I have not had a lot that experiences significant constipation, but I've had some that we had to take off because they were losing too much weight, particularly older patients that were on it, and they were just got to the point where the weight.
well, one
The
of the
most
reasons I
common
mentioned the
reason
gastroparesis.
that we start, huh?
No, and go ahead. You get froze for a moment. Go ahead.
Oh yeah, no, I was saying that we have not encountered a lot of patients experiencing gastroparesis, a very small percentage. Primarily, we're stopping the drug because they can't deal with the nausea. Some of them just can't deal with the nausea, and I mentioned earlier about weight loss. They're like particular some older patients, the weight loss may be too significant. And so we just back off of it, just take them off of it because they're just dropping weight so much.
Well, the main reason I mentioned that is because of the outside use for right here when they talk about treating obesity, you see down at the labeling there.
You see that?
The main reason that a lot of us a lot of our patients cannot get those GLP-1s like Ozempic and Trulicity because because other people are using it for non-diabetic purposes in terms of weight loss. And those are the ones that we're seeing gastroparesis maybe unnecessarily. And I'm not saying don't use them, but what I am saying is that we have to be cognizant that you can develop gastroparesis, and that's one of those significant side effects, and that it is not a side effect free drug.
Yeah. Hey, Dr. Kane, can I say this? I know y'all close to the end, but I want to say this because there's some bootleg Ozempic out there.
Yeah.
And so I want to say this because don't be gullible, right? Semaglutide, which is an active ingredient for Ozempic, it ain't off the patent, right? So nobody can get access to semaglutide powder to formulate a compound, a compound in pharmacy to make semaglutide. So I don't know what what they're selling, but it's not the drug. And so please don't fall for that in terms of, go to your doctor, get it the right way. Don't buy anything over the internet because there are some people out there who are selling a compounded, supposed to be, semaglutide or whatever, but it's not the real stuff.
And Ms. Turner, just FYI, what we're seeing is a lot of physicians that are starting these weight loss clinics, and somehow they can get this really cheap semaglutide, have you come in once a week to get those injections and saying that it's going to help you with your weight loss. Now, maybe some of it really is semaglutide that the physician has ordered and paying for and making his or her money back by doing it once a week. But as Dr. Kirksey has mentioned, we are being inundated with bobo drugs. When you're in the hood, those bobo drugs out there, and bobo drug makers that are out there pretending to be real Ozempic.
Yes.
So I wanted Dr. Kirksey, before we end the show, and this is a great conversation, by the way, can you talk a little bit about, for our listeners who may have a family history of diabetes or may have been told that they are pre-diabetic, what should they be doing now so that they will not end up with a diabetes diagnosis?
Ms. Turner, that is a great question. And I have some great news, because type 2 diabetes can be prevented. You can definitely delay the onset. Okay. And so there are 3 things that you need to look at. Okay. Number 1, lose 7% of your weight. And how do you know what 7%? Take your current weight now, multiply your current weight times 0.93. Whatever you get, that's 0.93. You will get your 7% weight loss goal. You should try to do that over 6 months, okay, and sustain it, all right? How do you sustain it? You need to incorporate a minimum of 150 minutes, right? 150 minutes of moderately paced exercise. Not you don't have to go out and run a marathon, anything like that. 150 minutes of brisk walking 5 days a week. And you don't have to do 30 minutes in a whole block. You can do 15 minutes twice a day. It's all cumulative. Okay, those are things that you can actually lower your risk almost 60% by doing those things. You lose 7% of weight. Beg your pardon?
No, that's some great, easy advice. I mean,
but you need to know if you're at risk. So you can actually go online. You can Google diabetes risk test and go on and take the test. You can get your score. It'll tell you. But if you have high blood pressure, high cholesterol, you're overweight, more than likely you qualify for that. You know, you should go ahead and start doing some things. You have a family history that's positive. If you had gestational diabetes when you were during your pregnancy, then you're at risk for developing type 2 diabetes, and should incorporate those lifestyle modifications in play.
Dr. Kirksey, you have been absolutely amazing. And for those of you who may be tuning in, don't forget to subscribe to our YouTube channel, because we want to make sure that we're able to continue these great conversations with experts such as Dr. Kirksey and others that we've brought on, and all of the other social media platforms. Please follow us on like us on Facebook, subscribe to us on YouTube. And because I'm over 50, I don't know what Twitch is, but for those of you who know what Twitch is, just Twitch on, stream us on Twitch, whatever it is. I don't know how to say it. But
I've never heard of Twitch.
These younger folks have.
That sounds like a dance. It sounds like a dance.
Not the twist. Not the twist.
Dr. Kirksey, at the end of every show, we like to give our guests an opportunity to share their final thoughts. And by the way, once you come on and have such a great show, you're gonna have to come back. I already know it. So just know that. Put yourself on notice that you're gonna have to come back. But please share your final thoughts regarding tonight's discussion, because again, it was amazing.
Well, first of all, thank you for this opportunity. Knowledge is power, and we all have to work to educate, our communities in terms of how they can best, manage this disease. Let's not ignore it. Let's all, respond to the alarm, because there's an alarm at the door. Okay, there's 37 million people living in this country with type 2 diabetes. Okay, 95% of those people have type 2 diabetes. Black folks are 2 to 1, 2 times as likely to have diabetes, and almost twice as likely to experience the complications such as blindness and so forth. So we know that we can prevent a lot of those things from happening by getting people controlled and by getting them on the right medications. So engage your healthcare professionals that, in your community. And I just commend you all for this right here. This has been a thorough, good, great discussion. The hour went by very, very fast. And
always.
Anytime you want to invite me back, I love to talk. And this is what I do. This is not a job. This is my passion.
Thank you so much. We really appreciate it. And I learned a lot from you. I was sitting here multiplying my current weight by 0.93. And now, Dr. Kirksey, I will say that's how I successfully got my A1C from its highest of 6.5 to 5.8 without medication, because every time I learn something from someone like you, who is Linda Brown, who's been on numerous times, as well as some of my other former colleagues at the health department, I get a nugget, and I tell people that take those nuggets. You don't make it overwhelming. Take a nugget. Linda said one week, and Dr. Kane, I'm gonna let you say your final thoughts. Linda said one week when I asked her to give a feedback on reading labels, she said, you don't have to read labels on the foods we really need to eat.
I like that.
How simple can you get? Right?
I like that.
Exactly. So the fruits and vegetables, you don't have to read labels, the things that are grown.
Long as you
rest
get
my
fat back in them, right? Right.
exactly. Dr. Kane, what are your final thoughts regarding tonight's topic?
The only thing I probably want to add just real quick is that Dr. Kersey mentioned earlier, insulin is when you get insulin resistance, you have to remember insulin is an antibiotic hormone. It helps to build body mass. You know, just like testosterone helps to build body mass, so does insulin. Problem is, insulin is more of a muscle building body mass, testosterone is more of a muscle building body mass, and insulin is more of a fat building body mass. And when you get, the more fat you get, the more insulin resistant you develop. Yeah. So the goal is to try to decrease your insulin resistance. A lot of that can be done by what Dr. Kersey mentioned earlier, and that was by the proper diet and exercise. Now, what I want people to remember, because I have a lot of people say, Dr. Kane, I walk every day and so on, so on, so. Muscle building, if you incorporate some muscle building into your exercise regimen, it does not have to be you want to be Annette Schwarzenegger or Arnold Schwarzenegger. All I want you to do is put some muscle, because muscles are much more sensitive to and have much more insulin receptors than fat cells. And so by doing that, they will reduce the amount of insulin you have, and that's how you would help to start losing weight and reverse that vicious cycle you get, where it's like, I don't understand it. I'm not eating a lot. I'm not doing this, but I'm still not losing the weight. It's because of insulin resistance, and you'll need to break that vicious cycle as to what insulin does in terms of its effect on your body.
How often, Dr. Kane, should you do the and I say weightlifting a week?
Resistance, mainly like resistance training, really it's the same thing, right? Resistance. Right. So, every other day, you actually do every other day, because you can alternate. You walk can one day, do resistance, and simple a resistance band. I tell a lot of my patients, when you're sitting, you can get them from Walmart for like $10, and it looks like a jump rope, but it's really like a big rubber band, and they have different strengths. Get you that medium one, and you can do arm lifts, you can do everything, but you're working those muscles. And you can do that sitting at home. You can do that sitting behind the desk. There's a lot of things that's a simple way to do that without going to the gym or anything like that.
And that's what I wanted you to break that down. And I even have told people in the past, Dr. Kirksey, just, go in and grab a bag of that rice or whatever, flour or whatever that you have, big can of baked beans or whatever, obviously all the things that we have in our pantries, right? Right. But until you get to the store to buy the resistance bands.
Since you asked that, Ms. Turner, just make your aerobic exercise, which might be the walking, for those that are really want to be challenged and go jogging. More power to you, since I got so old and the knees don't work like that no more. But if you just do half and half, since he said 150 minutes, let's get about 75 minutes of resistance exercises and 75 minutes of those aerobic exercises. You can do those, and even you can, for those Black women that don't have to worry about their hairdo no more, you can get in a pool and you do a whole lot of you do both when you're in a pool, but you don't have to submerge your head up under water. You can just walk in the water, because the hardest thing the only thing harder than walking on water is walking in water. So if you can go and do that kind of exercise, you will do great.
Yeah.
I rest my case.
Well, tonight's discussion has been wonderful. Tune in next week, because I promise you we're going to have an even better, not better, but another great discussion.
Nutraceuticals.
Nutraceuticals.
Oh, that's great.
And we bringing in Dr. Linda Brown, if she's available as well. And another family
I'm going to tap into that myself just to get educated.
Come on down.
Thanks again, Dr. Kirksey. Right. Thank you, Dr. Kane.
All right.
Welcome to Pause for the Truth. We are grateful that you joined us today and hope you've gained valuable insights on our current topic. We look forward to having you with us next time as we explore trending issues in our community and discover ways to simplify life for you and your loved ones. Our dedicated panelists and staff are committed to sharing knowledge and serving our community. But now, we need your support. Please subscribe to our YouTube channel and spread this valuable knowledge to others. Don't forget to invite your family and friends to tune in to our podcast every Tuesday at 6:30 p.m. EST. Visit our website at www.pauseforthetruth.com and show your support by liking us on Facebook, following us on Twitter, and linking with us on LinkedIn. Feel free to email us with any questions, or concerns, or show topic recommendations at info@pauseforthetruth.com. I would also like to give thanks to our behind-the-scenes technology engineer, Tyrone Jackson, owner and operator of Call Tyrone. Go to www.calltyrone.net for a complete list of services. Thank you for being a part of Pause for the Truth. Together, we can make a positive impact on our community. Good night.
All righty.